So the first thing you're going to do is you call your patient, and you ask to speak to the patient if someone else answers the phone. You have a brief discussion of the start of care visit and when it's going to occur at a time that's good for the patient. Most people would give a window. I would caution you to give yourselves a 4-hour window of time and not hold yourself so closely, or that you will call the patient so many minutes before you get there, when you're closer, so on and so forth. So what items can be answered by calling the patient? Well, the M1210, ability to hear. Can the patient hear you? And you're in your speaking voice over the phone. Do you need to raise your voice? And if you do need to raise your voice, again, what does that bring to your mind? Can the person hear the phone? Are they hard of hearing? Do they need an adapted type of phone? Do they have one and they're still hard of hearing? Do they need a hearing aid, or they have one and they're not wearing it? So all of these questions can be going through your mind. So did the patient answer the phone? If not, why? Are they in bed and bedbound, or they're too weak to get to the phone, or they are too demented to use a phone? Is there a physical reason, a cognitive reason, or is it the patient's choice? I don't want to talk on the phone, which we've all had, I'm sure. I know that I have had that, not as a patient, but as a person. There are times I really don't want to talk on the phone. Again, now we have to think about issues that might come about if the person doesn't answer the phone, and we get the sense that there might be a reason for this. So we want to think about the safety, the level of supervision now required for this person if they do have cognitive deficits. Can they access emergency services if they need them and they live alone? So again, we're thinking about this in education and teaching components. And we do this without thinking. You know, people say to me, you know, I don't know, do I think like that? You do. You might not be conscious of the exact line of thinking, but you do think like that. Your mind works like that. So again, can the person understand the verbal content? Are there hearing issues? Are they speaking another language that you don't speak and you may need an interpreter? So again, might be a barrier to an accurate data collection if you don't have an interpreter. So we think about this for, you know, capabilities, language capabilities of the staff. Again, the safety level of supervision required, ability to access assistance in emergency. And then again, talking on the phone, speech and oral expression of the language. In the patient's own language, of course, the primary language is key. But again, can the person physically and cognitively communicate with you? Augmented speech, so if a person talks, has had a laryngectomy and talks through an electronic device, it is considered the verbal expression of language because they do have to think about and make up and do a response. If they have a tracheostomy, again, further evaluation, of course, is going to be needed, plus a physical assessment of the trach. Sign language or writing is not considered to be verbal, so the person is unable to respond. But again, you're hearing something. The person is deaf but does know sign language. And again, you need to think about this in terms of your teaching. What tools will you use for that person? How will they be able to access emergency services? A formal pain assessment and frequency of pain interfering with activity. Now, we cannot really assess pain through the phone, but what we can do with this particular question is listen. Listen for grunting or moaning, or the patient being quite upfront with you. I'm in terrible pain today. You can't come. Or, I'm in terrible pain. Can you please come? So again, while you're not assessing the pain, you are listening to the person, and in some ways, you're getting an advanced amount of knowledge about what might be when you reach the home to see the patient. So again, it's part of the care plan, and it might be part of the education and teaching that you might have to do. So you get to the patient's home, and you greet the patient at the door. You wait for the patient to answer the door. You can always time the patient and how long it does take them to answer the door. And you introduce yourself, and you explain why you're there. You're there to do a start of care assessment, or you're there for your visit. And then, excuse me, when you're invited into the house, you can ask the patient to sit in a comfortable place that you want to begin your visit with the patient. And then you can begin assessing the environment as the patient is doing this. You can look around, and we all do this. We see the environment. We can tell the condition of the home, maybe by the outside, certainly by the inside. And sometimes what it looks like on the outside is totally different than what it looks like on the inside. I have seen gorgeous houses outside, and they are hoarders inside. And I have seen very run-down and neglected outside of the home, but inside of the home, it's kept well. It may be old, but it's very functional, and it's kept very clean. So assessing the environment is very important because it is going to impact in a peripheral way of how this patient will work with your plan of care, how fast the patient can move forward in progress towards goals, and the outcomes of the patient. And so we continue assessing now. We've greeted the person at the door, ability to hear, understanding of verbal content, speech and oral, and again, pain. Now again, with pain, and I'll go through this again in another slide, you can watch them now. Do they limp? Do they walk strangely because they have a limited range of motion in their hips? Can they walk at all? Do they greet you at the door in a wheelchair? So, with pain, you can readily assess. Sometimes you see grimacing as they turn to move. They frown, or their face scrunches down, their eyes close. You may hear some verbal interaction at that point in time, too. Again, now, what items can be answered? We've talked about the other items. We go now to 1400, noticeably short of breath. Is the person short of breath at the door that they came to open the door for you? Are they short of breath when they go to sit? Are they short of breath during conversation? And you can estimate the feet that it takes them either to get short of breath or to be short of breath. And that does make a difference in terms of what they're able to do. The impact of SOB is quite important on a person's ability to function. If the person couldn't greet you at the door, was it because they had trouble breathing, or they couldn't move, or they're too weak, etc.? So again, we have to think about this in the safety or the ability to care for themselves. Do they need supervision at all times? Can they access emergency care?